Okay, thank you for being an audience for this. This is the second talk. Last month I talked about alcohol withdrawal and how we treat it in 2015. So today we're going to go on into opiate and benzodiazepine addiction and how we treat it, how people recover from it. Just so you know, opiates include heroin and the prescription opiates, the prescription pain medications, and benzodiazepines refer to tranquilizers, medications like Valium, Klonopin, Xanax, those types of things. So those are two of the common addictions that we see, two of the common addictions we need to treat down in detox, two of the common addictions that we need to treat ongoing. So I'm going to start with opiates and then go to benzodiazepines. With opiates, it's an epidemic. It's a local epidemic, it's a city epidemic, it's a national epidemic. Heroin and prescription opiates are a big problem nationwide, as everybody knows. Drug overdoses are the leading cause of accidental death in the United States. More than 36,000 deaths per year happen because of opiate overdoses. There's 2 million Americans dependent on opiates. Some of those are prescriptions, some of those are heroin, but 2 million Americans dependent upon opiates. 4.5 million in the United States report a non-medical use of prescription opiates in 2013. Heroin dependence has doubled in the last 10 years and tripled in the last 3 years. So it's just going out of control. 10% of 12th graders are now using opioids, 10%. 80% of patients with opioid use disorder do not receive treatment. That's the great need out there versus what we are serving. As far as heroin goes, there's a natural history of heroin addiction. The mean age of onset of heroin addiction is age 18. 15 years later, 14% of those are dead. 25 years later, 28% are dead. And 30 years later, 50% of heroin addicts are dead. Not just suffering, but dead. So heroin addiction and all addictions, alcohol addiction, any of the addiction, is a fatal illness. 25% relapse rate even after 5 years sober for opiate addiction, and that's much higher than alcohol addiction, for example. So let's go on to see what we do for these people. We're going to talk about opioid withdrawal. Some of the things that you need to know about opioid withdrawal are that the severity of the withdrawal is directly related to the personality of the patient, the expectations of the patient. I've had patients that really didn't expect to have much withdrawal when they stopped using their opiates, and they didn't have much withdrawal. Other patients can be on 2 Vicodin a day and they're worried about it and they're going to have a lot of withdrawal. So what the patient expects is a big deal when it comes to opiate withdrawal. It's very different than alcohol withdrawal. Alcohol withdrawal patients are very seriously ill, but they frequently deny how bad they are. They deny that they're shaking so much, that their blood pressure is up, or that they tend to minimize their withdrawal. Whereas opiate addicts aren't in as much danger. It's not as dangerous. They're probably not going to die if they were put on an island somewhere, but they feel like they are. The dread, the fear, the horrible sense of what's going on, the need to relieve that symptom is so great with opioid withdrawal compared to alcohol withdrawal. So what does opioid withdrawal look like? There's several stages. It begins about 8 hours after somebody last uses. That's why heroin addicts and other opiate addicts have to use several times per day. It starts with the runny eyes, lacrimation, runny nose, yawning, sweating. About 12 hours later, if it's time to sleep, they won't be able to sleep. They'll have restless sleep. Stage 3 is going up to the first 24 hours. The pupils will dilate. They get anorexic. That means they lose their appetite. They get goose flesh, get restless, they get irritable. They get a little bit of a tremor. Not as much of a tremor as the alcoholic, but they will have some tremor. And then it peaks. It peaks about 2 days to 3 days after the last use. When we treat people in detox here, we don't let them get that sick. We don't let them go that long. But if anybody had to cold turkey it, this is in jail or whatever, this is when it peaks. And the symptoms of opiate withdrawal are these: irritability, insomnia, anorexia, violent yawning, sneezing. Coryza is just symptoms of a cold, that head cold sensation, chills, hot and cold sensation. They frequently will describe, when I ask them, what symptoms are you feeling? They say, I'm hot and I'm cold. They get this weakness, depression, craving for just relief of the symptoms, craving for the drug, nausea and vomiting, intestinal spasm, stomach cramps, diarrhea. Tachycardia is a fast heartbeat. That's one of the things you see pretty quickly when I'm doing the exam on the patients down there. Even if they're just starting to feel bad, the heart's starting to pick up. High blood pressure, sweats, sensitive skin, intense fear of withdrawal. That's key. Bone pain, muscle pain, kicking movements. And that's where the term kicking the habit came from, is from the kicking movement of a heroin addict in withdrawal. And then it can go on afterwards. When people do recover, they get done with this acute withdrawal, there can be what's called protracted opioid withdrawal, which can go on for weeks or months later if they're not treated, if they're not on medication, if something's not being done. Later on, they'll have anxiety, depression, sleep disturbance, fatigue. They just won't feel well. The dysphoria just means you just don't feel well. Irritability, decreased ability to focus, and deficits in executive function. They just won't be thinking as well. And that's why the relapse rate for an opiate addict that's not being treated with some type of a medication is so high, so high. Then we'll talk about that as we go on. So what we do downstairs, well, we take a look at the addict, and the nurses will try to give them a score. There's a number that you can put if you measure all these things. It's called the COWS score, Clinical Opiate Withdrawal Scale. And that can put a number on it. You check the pulse and the sweating and the restlessness, all these things up here, and they can put a number on it. It's not as critical as the alcoholic, where we put a score on and that guides the medication. This just gives us an idea of how somebody is doing. I wanted to say something about the theory of addiction. Patients with addiction have a low dopamine tone. They have, dopamine is one of the chemicals in the brain that affects the way we feel, affects our craving, affects our mood. So the ultimate question is, what makes an addict an addict? How is an addict different from somebody in the normal population? What makes them keep using? Those are the ultimate questions in addiction treatment. The ultimate goal when we treat addicts is to make a recovering person. So the person with addiction has this low dopamine tone. They're born with it. They have lower dopamine tone than the person that doesn't have this disease of addiction. This dopamine tone being low can be just due to low dopamine receptors, or just the decreased amount of time that the dopamine is on the receptor. So all of those can create low dopamine in this patient. So something happens as this person is born, that's wired this way with addiction, with the disease of addiction. Something happens in their life that they get this dopamine spike. It can be hitting a home run in Little League. It can be getting a good grade. It can be doing something and they get this feeling good. Or with an addict, it can be their first use of a chemical. And then that dopamine tone, which was low, is raised up and they feel, bam, better than ever. They feel like this is what's missing. This is why now I feel like the normal person, and it's amazingly reinforcing. The problem is the dopamine receptors then compensate. They close down, and the person crashes and goes to an even lower dopamine tone, and then they have to keep using and keep to just to feel normal, and then you've got the symptoms and you've got the disease of addiction. As the person goes on and they have this low dopamine tone, they will have decreased attention, they will have a decreased connection with others, decreased joy in their life, decreased ability to experience pleasure. So how does that person recover? How do they do it without drugs? They can do it by helping others, by altruism, by 12-step spiritual recovery. All of these can actually, without medication, increase that dopamine tone. Addicts with dopamine depletion feel isolated. They feel less than others. People that go to recovery meetings that they like and they feel supported and that get a spiritual answer to their recovery have a sense of that they know they're not alone and they know that they're not less than others. So that's how not only medication but actually a recovery program can help somebody with this disease of addiction. So how do we treat opioid withdrawal? Well, one of the things we used to use, these are the medications that we've used, and one of the older ones and first ones we used was clonidine. Clonidine is a blood pressure medicine. It's an alpha-2 agonist for those with a medical background. It's the main medication that we used for treatment between the time I started here in 1978 up till 2003 when we changed the way we treat it. Well, clonidine will block the opioid withdrawal. The dose is whatever's tolerated. You know, the usual dose for blood pressure is a 0.1 milligram twice a day. Well, if you can give more, you just have to watch their blood pressure. The more you can give, the better. Sometimes you need to use 0.2 or 0.3 milligrams 3 or 4 times a day. The problem with clonidine is it has side effects. It causes a dry mouth, it causes lethargy, it causes dizziness. So then we go on to the second medication, methadone. Methadone is an opiate. That's why it does relieve opioid withdrawal. It's a pure opioid agonist. We're limited by federal law to using methadone for just 3 days. So sometimes we come in when people don't want to use clonidine, they don't want to use buprenorphine or Suboxone. We give them 3 days of methadone, and it works a little bit, but they have a little bit of withdrawal after the 3rd day. So that's what we can do with methadone. Benzodiazepines is number 4 up there. That doesn't relieve opioid withdrawal, but it relieves anxiety. And by relieving anxiety, it can be helpful. So we'll frequently use it in the first 24 hours before they can get buprenorphine. We don't use it after detox. We got to get them off of it pretty quick because obviously the benzodiazepines, and that's what this talk is about, are an addicting drug in and of themselves. So buprenorphine is the main drug we use downstairs. That's the brand name of buprenorphine is Subutex or Suboxone if it has naloxone in it. And it became available for use in 2003. And it's an interesting drug. You know, heroin and methadone and oxycodone, those are what are called full agonists. They go to the opiate receptors, bind to them, and stimulate them fully. Full antagonists are drugs like Narcan, naloxone, naltrexone. They go to those receptors and just block them. They don't stimulate them at all. But buprenorphine is both. It's an agonist and an antagonist. So it goes to the receptors, it knocks off any drug that's on the receptor, and it binds to them really, really strong, stimulates them a little bit to take a person out of withdrawal, and then blocks them the rest of the way. So you go from withdrawal to kind of normal, and then you can't go any higher. It's a very strong drug. It's got a high potency, high affinity to the receptor. If you take a buprenorphine pill or if you swallow it, it doesn't work. It's very poorly absorbed from the gastrointestinal tract. It's better if it's under the tongue. That's how it's absorbed. And they have a form now that they can put on the inside of your cheek, and it's absorbed even better that way. It has a ceiling effect. The more buprenorphine you take, you don't get more effect because the receptors are blocked. How do we use buprenorphine? We can use it for induction. Induction is when we take people from the heroin or oxycodone or whatever they're using and get them on the buprenorphine and use it for detox. You have to be careful because the patients have to be in withdrawal. It has to be at least 24 hours after they last use an opiate before you can use buprenorphine, or else you'll cause a precipitated withdrawal. Buprenorphine will go in and kick the heroin off the receptors, and the buprenorphine is not strong enough, so they actually get worse if you give it too quick. Some of the addicts use buprenorphine on the street. They get Suboxone from somebody else, a friend, and they use it too quick, and it actually makes them sicker. So that's precipitated withdrawal. It can be used for a taper. That's what we frequently do down in detox. You can put people on it and then taper them off over the course of a 1 week, 2 weeks, 3 weeks, maybe even as long as four weeks. There is withdrawal when you taper somebody off. The 2 weeks seems to be about the best balance. If you do it shorter, they have too much withdrawal. If you do it longer, it seems to be harder to get off at the end. So 2 weeks seems to be about the best. So there is withdrawal when you taper it off. The question is, how is it tolerated? And again, that depends upon the personality of the person. If they're expecting to have a lot of withdrawal, if they're worried about it, if they're expecting there to be no withdrawal, they're going to be disappointed because there is some. After the taper, after they get off, they're on nothing then. After those 2 weeks, it's a problem because they'll have a lot of craving, a lot of preoccupation, a lot of thinking about the drug, and there's a high relapse rate right when you finish the taper. The next thing you can do for an opiate addict downstairs in detox is don't use buprenorphine and just use what we call a non-opioid detox. And the purpose of this is so that we can enable the person to get to using the blocking drugs, the naltrexone, the opioid blocker. We'd like to be able to use that, so in order to use that drug, they have to be free of all the opioids for 2 weeks. So sometimes down in detox, we start by detoxing them with non-opioids, without buprenorphine. So this is basically a bridge to get 2 weeks from the last use to that antagonist. Naltrexone, it's also called Vivitrol. So clonidine is a choice for a non-opioid detox, but it's not really strong enough. So one thing we came up with, and we found from studies around the country, is to use these 3 drugs, these 3 medications for our non-opioid detox. Tizanidine, 8 milligrams every 6 hours. That's kind of like clonidine. Hydroxyzine, 100 milligrams every 4 hours. That's a big dose. And then gabapentin, which is a seizure medication. It's an anticonvulsant. So when the patients take these 3 medications, they feel tired, they feel wiped out, they spend most of the day in bed. But they actually do pretty well. They can get through the heroin withdrawal, they can get through the opioid withdrawal. And then when they come out at the other end, they don't need to come off of anything else. They're already starting that 2 weeks.